Welcome, everyone. Thank you so much for joining us today. My name is Amanda Wilkeson. I'm a nurse on PPMD's care team, and we are here to host a webinar to talk about bone health. Before we get started, I'm going to ask each of our panelists today to introduce themselves, and then we'll dive into some presentation before answering questions. As a reminder, as our panelists are talking, please feel free to submit any questions you have in the chat, and we will get to as many as possible. So first, I'll throw it over to Alexis from PPMD to introduce herself.
Hi, everyone. My name is Alexis Hazlitt. I'm also a nurse with the care team with PPMD, and I will be co-hosting this with Amanda. Happy to have you guys here.
Thanks, Alexis. Dr. Ward?
Well, hello, PPMD viewership. Always a wonderful opportunity to engage with you. My name is Dr. Leanne Ward, and I'm a professor of pediatrics at the University of Ottawa in Ottawa, Canada, and a pediatric endocrinologist at the Children's Hospital of Eastern Ontario. Really great to be here today. Thank you for the opportunity, PPMD.
Thank you. Dr. Merchant?
Hi, I'm Dr. Merchant. I'm a pediatric endocrinologist and geneticist at Children's National in Washington, D.C. And thank you for having me here. And I'm looking forward to speaking to all of you here. And thank you for PPMD for giving me the invitation to talk to all of you. And I'll be talking about growth and weight and adrenal insufficiency. So we'll hear about that more.
Great, thank you. And Dr. Crane?
Hi, I'm Dr. Janet Crane. I'm at Johns Hopkins University. I see most of my Duchenne patients through the Kennedy Krieger Institute, and some of them through Johns Hopkins. And I do both. I'm board certified as pediatric endocrine, but I also take care of many of the adults in our DMD clinic. And I'll be talking about puberty.
Great, thank you all. And with that, I will hand it over to Dr. Ward to get us started. And again, please submit any questions you have in the chat.
Great. So as Alexis and Amanda said, we're going to be talking about bone health today, and specifically the endocrine issues that can impact bone health. And this is a really important topic. These are my disclosures. And important to understand that all the osteoporosis therapies that we're talking about today are off-label in children. That means they haven't been officially approved by health authorities like the FDA or Health Canada, but they are nevertheless widely used around the world. So we're talking about bone health. And when we talk about bone health, we really mean bone strength. And when bone strength goes awry, when bones become weak, we're talking about osteoporosis. So the medical term for what we're talking about today is really osteoporosis, but you'll often hear of it discussed as bone health or bone strength. As was stated earlier, we're talking about bone health in general, and that's my portion of the webinar. And then Dr. Merchant will talk about growth and weight management as it relates to bone health. She'll also talk about steroids and adrenal insufficiency. And then Dr. Crane will talk about the impact of puberty on bone health. So when we think about bone health, we think about the things that drive muscle strength and that go awry in Duchenne muscular dystrophy. So we know that the muscle weakness of the condition is largely responsible for the long bone fractures, that is the fractures of the arms and the legs, as well as other fractures like fractures of the fingers and the toes. And we know that the risk of a long bone fracture, like a femur fracture, is increased on steroids like prednisone and deflazacort. We know that vertebral fractures, fractures of the spine, are very infrequent. They can still happen, but relatively infrequent if you're not on steroids. And that steroids are largely responsible for the fractures in the spine, which are called vertebral fractures. You may also hear them being referred to as compression fractures. So these are examples of fractures. This is the femur, the biggest bone in the body, the leg bone between the hip and the knee. And here's a fracture in a patient with Duchenne. And then on the right, these are vertebral fractures along the length of the spine in an individual that didn't have regular bone health monitoring. The bones in the back should look like little ice cubes, and here they're compressed. So we know that bone fractures can occur frequently in Duchenne, and they can be serious. And that's why there's such a focus of conversation among all of you, and also a focus of education on the part of PPMD. We know that muscles and bones work really close together. I tell the children that I take care of that they're like peanut butter and jelly. They're talking to one another all the time and they're working together. So why are the bones fragile in DMD? Let's unpackage this a little bit. So in the typical setting, muscles are secreting molecules called myokines, which are favorable to bone strength. The muscles are telling the bones, you've got to be strong. I'm walking around and running and you need to be strong. And they do that by crosstalk. And then in Duchenne, the muscles, because of the weakness, are not sending those same bone strengthening signals. There's also just lack of weight bearing, which is also a mechanical drive for the bones being stronger. And then steroids also tickle the bones, and they do that in anyone. Anyone taking steroids at the kinds of doses that are used in Duchenne for long enough will also have issues with their bone health. And when I talk to the children about this, I say that the steroids are tickling their bones, and that's expected. That's what steroids do. We know that this is a consequence of the benefits of steroids to muscle. So in the typical situation, there's 3 bone cells, the osteocytes, the master bone cells, the osteoclasts, which resorb and get rid of damaged bone, and the osteoblasts, which lay down new healthy bone, that these cells all work together to keep the bones strong. Steroids, again, in anyone, just put these cells to sleep. They're sluggish. They're not working as well together. They're not working as hard. And so the bone isn't being refreshed and reinforced as it should be. And this occurs not only at the femur, as I just showed you, but this also happens in the spine bones. In fact, the spine is very sensitive to the effects of steroids. It is what's called trabecular bone, and trabecular bone is well known to be very sensitive to the adverse effects of steroids. So we put a lot of emphasis on monitoring the spine. So how do we evaluate bone strength in the clinic? Well, we certainly ask at every clinic visit about fractures. We'll say, have you had any broken bones? And we'll go through the list of fractures and we'll invite the family to tell us about any concerns they've had about injury or fracture, or even just areas of the skeleton that are painful that they want us to explore with an x-ray, whether there might be a fracture. We look at bone density testing by a machine called DEXA, and I'll tell you more about that. And we look at the spine and the hip. We also have the option of looking at the whole body BMD. And we do imaging of the spine, either just plain x-rays from the side, or the DEXA machine in some centers can also give us a picture of the spine to help us understand if there's those little compression fractures that I was mentioning. This is how, as clinicians, we look at the bone density. This is at the hip and the spine. The hip we don't start to do till the boys are older, like over 6 or so. The spine we can do at any age. We're basically following the bone density over time, and we're looking to see if there are what we say clinically significant declines in bone density. So these little squares are a given patient and that patient's bone density over time. And we say that if the bone density declines by more than half a standard deviation, or a 0.5 Z score, or Z score, as you say in America, that's clinically significant. And that would prompt us, if we're seeing that at the spine, to do an x-ray a little earlier than every 1 to 2 years. This is an example of those little ice cubes at the baseline here, where there are no fractures, starting to compress a little bit, telling us that the strength in the spine is not keeping up. So this is a boy with Duchenne. I do a baseline spine x-ray around the time of steroid initiation. He has a normal spine. And then a year later, at what's called T9, that square is just becoming a little rectangular. And then a couple years later, in the absence of treatment, there's more collapse. So this is called the vertebral fracture cascade, where a fracture of the spine at one time point is associated with an increased risk of even more fractures down the road. So we like to treat really early to try to prevent that vertebral fracture cascade. So as a minimum, we start bone protection therapy at the very first sign of a fracture, even before there's back pain. potentially. And so we're doing that spine imaging periodically. And the moment we see the spine bones are not able to keep up and maintain their strength, then that's an indication to start bone protection therapy. Now, you may say, which treatments should we use? And there's different treatments that people use around the world. There's intravenous bisphosphonates, pamidronate and zoledronic acid, and there's oral versions of these medications, alendronate and risedronate, for example. Most clinics use the intravenous form of bisphosphonates because it goes from the vein right into the bones. The oral agents go through the stomach, and the amount that gets from the stomach into the bone is less than 1%. So the IV agents are stronger and have more of an effect on bone. The oral agents are weaker. They still have an effect on bone, but not to the same extent. The IV agents also come with more side effects with the first infusion, and sometimes even the second and third infusion, feeling like you have a cold, achy, muscle pain, bone pain, and that can be very disturbing to families, and we appreciate that, and we support the families with recommending something for fever and something for bone pain, and something for nausea. And then the oral agents, because they're weaker agents, they don't tend to have the same in the way of side effects, although some patients can have some side effects. So you would discuss with your physician what they're doing in their clinic. But the typical recommendation is to go with the stronger agent because this is a fairly aggressive bone health problem. This is how this looks all mapped out. We recommend bone density testing around the time of diagnosis or steroid start, with a bone density test yearly if it's available. If it's not available, that's okay. The most important thing is the spine imaging. That's done every 1 to 2 years if you're on steroids, or every 2 to 3 years if you're not on steroids. And we do the spine imaging with an X-ray or by DEXA more often if there's back pain or if the spine BMD falls by more than half a standard deviation. And then as a minimum, we start at the very first sign that the bones in the back are starting to get a little weak, or if there's a fracture anywhere else in the body, and continue bone protection for as long as you're on steroid therapy, and maybe even longer if your clinician feels there's ongoing benefit. How do we monitor this response to bone protection therapy? Well, we ask about fractures, we ask about back pain, and we're looking to see the trajectory of the bone density at the different skeletal sites as well. And we also repeat the X-rays to make sure that any changes in the spine are stable. Sometimes they can progress a little bit, but typically you will not have back pain when that happens because of the extent to which these IV medications are very good for back pain. Now, many people say, why not start bone protection before a first fracture? And that is a great question. Starting at the time of a first fracture is the minimum standard of care. If you work are seen in a clinic where they start even before first fractures, that's great. But as the minimum, we want to see patients on treatment at the earliest sign that their bones have lost their strength with a fracture. Signs that your child may benefit from starting bone protection before a first fracture, or you yourself, is weight gain, slowing of growth, rounding of the face because of the steroids, and bone age delay. These are all indicators that the bones are seeing a lot of steroid. Declining muscle function as well can be a sign that you may benefit from starting steroids even before a first fracture. And what are the expected benefits? We certainly expect fewer fractures, less or no bone pain with bone protection, and also we're trying to lower the risk of something called fat embolism syndrome when there's a bone bruise because of an injury or a break in the bone, and that releases fat called adipocytes into the bloodstream that can shower the lungs and also get into the brain and cause confusion, disorientation, and troubles breathing. Any patient who's had an injury, a fall, even if they haven't broken a bone, who has confusion or respiratory distress needs emergency medical care to take care of this fat embolism syndrome. We hope that by keeping the bone density up, that this will prevent those fat cells from leaking from the bone and getting into the bloodstream. So that's your introduction to bone health and osteoporosis. I'm going to turn it over now to Dr. Merchant, and she's going to talk about growth and weight management and also adrenal suppression due to steroids. Dr. Merchant.
Thank you. Let me just share my slides. There we go. All right, so I'm going to talk about adrenal insufficiency, growth, and weight. And these are my disclosures, nothing related to this topic. So glucocorticoids, which is is the most widely used treatment for DMD. We use it because it prolongs ambulation by 2 years. It reduces the frequency of scoliosis and improves cardiorespiratory function and a lot more. But here today, we're talking about some of the side effects of it. So systemic steroid exposure can lead to adrenal insufficiency that we ourselves are going to cause because we're giving daily steroids or periodically, depending on what regimen you're on, and affects growth and weight. And we're going to go into it in a little bit more depth. So PPMD has been doing a lot of great work trying to increase awareness, especially after PJ Nicholas protocol. That was a boy who has 31 who one of the reasons that may have passed away from was adrenal insufficiency and not being treated adequately. So what happens is steroids, depending on which one you're on, can affect it suppresses the body's own production of steroids themselves. And so this leads to having not enough steroids in case of illness. So how do you know you're in an adrenal crisis or you need more steroids? If you're having dehydration, infection, any kind of, if the steroids are stopped suddenly, we know we have to wean, and if there's a surgery or trauma that happens. And then the symptoms are really important to be aware of, so we adequately treat the steroids. And hopefully most of you are all aware and have these Solu-Cortef injections available at home in case of an emergency if we're not able to take oral steroids. And so there is a protocol and hopefully a letter that we recommend families to carry, so that way we know what to do in case of an emergency, which you would want to talk to in depth with your primary endocrinologist or neurologist of what to do to make sure that you're giving appropriate steroids based on if you're having fever versus having a fracture, or if you're really extremely sick. We have different ways that we want to taper to make sure that safety is our biggest concern and making sure our body can fight appropriately when we do have an injury of some sort. So growth, what does steroids do to growth? We know that growth in boys with Duchenne muscular dystrophy, even if they're not on steroids, can be affected with growth. And this, based on the growth charts that we have with some data collected, it's about 4.3 centimeters shorter, which is about one standard deviation, about 2 inches less than what would be expected in midparental height. What is midparental height? So midparental height is determined by mom and dad's height. And then and that's how we figure out roughly how tall a child should be. And then you get steroid. We already know Duchenne muscular dystrophy boys are at a risk for being slightly on the shorter end. And then they have normal birth length. And then they also have, even if they're naive to steroids, they do have normal growth factors, and they respond normally to growth hormone stim tests. So it's not that they have growth hormone deficiency, they just innately have low or less growth. Then you add steroids on top of that, and steroids slows down the bone growth. It delays the skeletal maturity. So if you get a bone x-ray, it'll show that the bones are slightly delayed compared to the age of the child. It decreases the linear growth. It also inhibits the chondrocytes, the bone cells, to really kind of increase in proliferation, increasing in the bone turnover in a sense, which is what we talked about earlier. And so when for example, in this growth chart, you can see that this child was started on steroids and then their growth decreased slightly. It wasn't increasing at the same range that it should have been. And so there is some altered activity of the growth hormone secretion, but they're not really growth hormone deficient. And so the slowing, but then if you take them off of the steroids, there is some catch-up growth that occurs in any patient who's on steroids, and also in those with Duchenne muscular dystrophy. So the growth delay is based on somewhat the regimen that you're on. So we know that growth delay is less common in those who are on intermittent steroids compared to daily. It's more common in daily deflazacort. There's more of an effect on growth than in prednisone. And then there's some early studies that show that the vamorolone, which is currently being studied, has less effect on growth also. So growth can be affected depending on what type of steroid, but in the general, it's very good to know that growth is affected by steroids. So what about growth hormone? We get asked this question all the time. We know that there's no known increased prevalence of growth hormone deficiency in patients with Duchenne muscular dystrophy. There is that tall stature may accelerate functional decline, and this is decline, which is based on animal models. So the question comes, should we treat or not? And there is the other question of whether quality of life may be better during ambulatory stage for those on growth hormone. That's really hard to tell, but there is no data to support safety or efficacy. So the care consideration had said at the time that we would say it's a case by case, and there's no evidence of growth hormone deficiency. But if there is, then it's not recommended routinely, but it can be thought through and assessed based on the child and the families. So what about weight? Weight is affected, as many of us know, with steroids. So there is an increase in weight velocity in the sense that the amount of weight gain that occurs in age 7 to 10 in Duchenne muscular dystrophy. And that could be because of change in ambulation, and some of them get started on steroids too. So there's a lot of different factors that can be affected. And so what we see is some of this has to do with weight, but also when you give excessive amount of steroids, you get certain features, which can include like a red rounded face, some acne, there's the weight gain. They can sometimes develop darkness behind the neck. And then also there is sometimes change in like sleep patterns, moodiness, anxiety, depression, and change in school performance, which could be due to steroids. And sometimes the steroid regimen is altered based on that. So here I have a child who was put on prednisone at the time of diagnosis. And then due to the significant weight gain along with change in behavior, we switched to deflazacort. And then I talked about mid-parental height. This is kind of where we would look at on the growth chart where we expect the child's height to be. And based on that, you kind of follow along on the growth chart. And it just gives you like things that we are looking for to see how the kid's growing, how they're gaining weight, and if they continue to accelerate in weight gain or if the weight is stable. So vamorolone there is the new question of vamorolone that's being studied right now, but there has not been shown that it is weight sparing. It may be a little bit for growth, but not for weight. So what do we do for weight management? As for every child, but especially in children with Duchenne muscular dystrophy, dietitian early would be very helpful. You want to avoid the early weight gain when you initiate the steroids. So you want to monitor the weight really closely. And we also know that losing mobility can also lead to weight escalation. And so all of these is kind of really working with the dietitian and seeing how the weight gain is happening to make those changes in eating habits of like, maybe a little bit less of sugary drinks. And all of those are different things that we can do to avoid having that excessive weight gain. And as they get older, some also have difficulty gaining weight and lose weight or have a poor appetite. So it is important to understand that this is not just happening only weight gain, but it can also get less as they get older, but we do want to manage early. So thank you. And now I'm going to pass it over to Dr. Crane to talk about puberty.
Thanks, Nadia. Share slides as well. So I'm going to talk about the impact of puberty on bone health. So puberty, what happens? I think we all know this, and I love asking my patients about puberty because it gets really awkward. And so I end up taking them through yes, no questions. And the way that I like to present it and approach it is asking for the least invasive things that they're more likely to respond to, and then get to the more uncomfortable questions. And so I often start with, are you experiencing any body odor, any acne, any changes in your voice? Have you experienced a growth spurt? Is there hair growing any place that it didn't used to be? But the real sign of puberty as an endocrinologist is that the testicles start to enlarge. And that is not something that most boys are aware of. And that's something as parents that I don't necessarily want everyone checking their teenage boys to see if their testicles are enlarging. So that's where we get to the physical exam, where we assess the size of their genitalia. Other questions is if the testicles have begun to enlarge and the penis has begun to enlarge, if they're experiencing ejaculations, and these can be spontaneous or non-spontaneous. And these are all very normal stages of development for a male going through puberty. Additionally, there are mood changes. They may be seeking privacy more than usual. I think that's a really important topic that I talk with my patients about because they're not trying to separate themselves from the family, and then because of the needs and their more dependency as they get older, it does need to be a conversation about giving them adequate amounts of privacy, and then hanging out with their peers or shifts focusing to peer relationships as well. So when is puberty supposed to happen? It should happen in males between the ages of 9 and 14. And what is happening? Well, the testicles should be enlarging. So if they haven't enlarged by the age of 14, we call it delayed puberty. And why do we even care, particularly from a bone health perspective, is that normally adolescents will double their entire skeletal mass during puberty. So if we're talking about fractures and risks of fractures, puberty in theory becomes a really important point of bone health. There's not a ton of data about puberty in DMD, except that we know that it's delayed. And questions are, should we be doing something about it? In my personal experience, 86% of my patients who are over the age of 14 were not going into puberty spontaneously on their own. And so they had delayed puberty. And we talk about the pros and cons of using testosterone to help push them through it gently, but try to nudge them into puberty. I will say that it's not a definite yes or definite no answer to whether you should use puberty. So when I've approached my patients and talked to them about using testosterone in delayed puberty, about half of them agreed to do it, and the other half wait it out. If you wait it out, many of the boys will go through puberty spontaneously, but what age it happens depends on the patient. So about 71% of my patients will progress through puberty, regardless of whether I gave them testosterone. And so I just show you a little bit of summary that we did when we analyzed 27 of our patients. The brown color on our graphs shows the boys who never were treated with testosterone. The light brown is because they were under 14. So I'm just watching and seeing if anything would happen. And over the age of 14, that was never treated with testosterone. So did have some delays in puberty, but was able to go through it spontaneously, versus the green colors have been treated with testosterone, where the dark green continued to take testosterone and needed it more than just the initiation of puberty. We grade puberty based on the size of the testicles and also on how much pubic hair there is. And you would expect them to move fairly simultaneously with each other. But what we see in the Duchenne boys is they make enough testosterone to get some body hair, but the size of the testicles don't quite increase as fast as we would expect them to. In regards to fracture risk, we did analyze the time of starting a treatment and seeing how it impacted vertebral compression fractures. And initially, what you look at it, there's a couple of things to note. So this is what we call as a survival curve. So it's 100% of patients entered in with no vertebral compression fractures and how many months until they sustained a compression fracture. And so the group that's treated just with zoledronic acid, which in my group means that they've had a significant fracture history, they quickly have another fracture. So by 2 months in, at least one person in the group has already sustained a fracture. In the group that's just treated with testosterone, so they've come to see me for other reasons, we've pushed them into puberty, they also fracture really quickly with at least the first one experiencing a fracture within just a few months. In the groups that are treated with a combination of zoledronic acid and testosterone, an initial fracture is about 1.5 years out. But that comes with a lot of bias, so we don't really like looking at the initial fracture. So we tend to look at, when we analyze these curves, is at what time point have half of the people sustained the event, and in this case, the vertebral compression fracture. And so if you've been treated just with testosterone, about half of the boys will have had a vertebral compression fracture about 14 months into it. If they're treated with zoledronic acid, 50% will have a fracture out a little over 2 years later. And if you've added testosterone onto zoledronic acid, we found that 50% made it about 5 or 6 more months before they had sustained their vertebral compression fracture. So it does seem to help delay the time to next vertebral compression fracture modestly. There's a lot of confounders with this. This is only 27 of our patients. The age that I initiated testosterone was variable. There are many other factors the boys are coming in that are influencing their fracture risk, including what their fracture history was like. I would say we've done additional analyses taking into account a lot of these factors, such as if they've broken an arm or a leg, if they've had a vertebral compression fracture in the past, how long they've been on steroids, the age they were, what their ambulatory status is, how tall they are, their BMI, and their bone mineral density. And after we adjust for all of these factors, there's still a slight benefit, slight meaning maybe 10% delay in the time for the next vertebral compression fracture when we add testosterone onto the zoledronate. So there does seem to be a little bit of benefit of pushing boys into puberty. We haven't been able to analyze the data yet on cardiac outcomes and respiratory outcomes to make sure we're not doing any harm, but that's in our next stage of analysis. Other things we don't know if our population that I'm seeing in Baltimore is similar to everywhere else in the country and world. People are using different bisphosphonate regimens, as Dr. Ward mentioned. We don't know what the best testosterone regimen to use is. There's several different protocols that people follow. And then what age to even talk about testosterone or push them into puberty is also unknown. So there's a lot of personal considerations when I'm talking to families that we'll go through and trying to figure out the best treatment for that individual. And so I will hand it back over to Alexis and Amanda, but thank you for the opportunity to speak today.
Thank you all so much. So we do have some questions in here. So the first one is for Dr. Crane. Could you just clarify the delayed puberty? Is that a result of Duchenne in itself, or is that just because, or just for boys who are on steroids?
That is an excellent question. It's mainly for the boys that are treated with steroids. We do know that children treated with chronic steroids tend to go through puberty later. And in my steroid naive patients, I've seen that as well, or the intermittent steroids are much more likely to progress through puberty spontaneously.
And then kind of piggybacking on that, there's a question about bone mass for boys who have gone through forced puberty, so through testosterone. Is that different than boys who go through puberty spontaneously? Is their bone mass and bone health different?
The we haven't been able to separate. We don't have enough patients to be able to say in what's happening in the progressing through puberty spontaneously versus we're pushing them through puberty. But what we do see is that they do acquire bone when they go through puberty. And so the bone density increases. It doesn't increase as much as you would see if you don't have Duchenne and on chronic steroids. And so the disease scores do still tend to drop.
Great, thank you. I have a question for Dr. Merchant and maybe Dr. Ward. Dr. Merchant, you talked a little bit about gaining weight. There was a question here about underweight as well. Can you speak to how either of those can impact or optimize bone health? And I guess where's the middle, the best outcome for weight on bone health?
So weight. So we say that there is an increased risk with steroids on for the boys that are on steroids for Duchenne muscular dystrophy, but I think that's a generalized statement, and I think it's individually, I would say this is just a general statement. We know that people who are on high dose steroids are at higher risk for gaining weight. Now, that's not for every single child, and also a lot of it comes down to the calories they're consuming. Are they ambulatory or not? There's a lot of other factors that may go in and also can be assessed for why they may or may not be gaining weight.
And I kind of have my own question. I'm not sure if you can answer this. This might be for a physical therapist, but do you have any feedback about how safe exercise can be beneficial for bone health?
Yeah, so I think we like to encourage as much as possible, but safety is really important when we talk about exercise. So those that are ambulatory, trying to encourage them for weight bearing a little bit is important. And Leanne Ward might have a little bit more to add on that, but I think that as much as we can keep them active, in a sense, just even moving as a little bit is really important. But safety is my biggest concern always.
Yeah, I could just piggyback a little bit there, if that's okay, Alexis. I mean, that's a really great question, right? Do you want to sort of push yourself to try to optimize bone health in this condition or not? And what I recommend is that we shouldn't be pushing the boys. We should allow them to be as active as they feel comfortable. We do know, though, that maintaining ambulation is a very important determinant of maintaining bone mass. There's a lovely study out of the UK by Nicola Crabtree, and she showed that once the ambulation is lost, then the bone mass in the legs really goes down, and we certainly see that by DEXA as well. So any effort to maintain ambulation is meritorious, and that's part of why we're talking today, because we want to try to prevent fractures that take boys off their feet as well as part of this narrative.
I'm going to piggyback on you too, Dr. Ward, and say it's not just the exercise, but it's the stretching that's really important as well. With the contractures, particularly of being able to get the heels to the floor when you're standing will help a lot with balance and help prevent those falls.
Yeah, that's a great point.
And then also the weight gain, I think it'll also make it more difficult to, if they do have that in between ambulation, if they're a little bit able to, but if they gain a lot of weight, they have a harder time and they're at higher risk for fractures. So I think that's kind of why we really do encourage and want to make sure that they're not gaining a lot of weight.
Yeah, and so you all had mentioned, steroids do help prolong ambulation, but at the same time are negatively affecting the bone health. And so when boys are non-ambulatory, are there still benefits to taking steroids once they're non-ambulatory?
Yes, I think the data is quite clear that there is ongoing benefit post-loss of ambulation to cardiorespiratory function. So the recommendation is to continue. Obviously, everything is a discussion with a family and a patient, but the recommendation is to consider continuing beyond loss of ambulation for the cardiorespiratory protection.
This one might also be for Dr. Ward, another question. someone asked about bisphosphonate therapy and that their son is 18 and no longer receiving it. Do you have guidance for how long patients should receive therapy and how often?
Yeah, that's a really great question. So we recommend, and in the care considerations, this is affirmed, that you continue bone protection therapy. So in this case, zoledronic acid, even beyond 18 years of age, for as long as the patient is on steroids, and maybe even longer, even if once the patient comes off steroids, there may be reason to continue. What we do as the patients get older, particularly once the bones in the hands have fused, which are consistent with the individual having reached physical maturity, we switch from zoledronic acid every 6 months just to every year. The individual needs a bone health evaluation anyway, even post 18. And so an annual visit with an annual bone protection injection is very reasonable, since the risk factors are persistent for fractures. That's a great question.
Would you give similar guidance to an ambulatory patient who's not on steroids?
Yeah, I think that if you're 18 and you're ambulatory, if you've never sustained a fracture, you've probably not been put on a bisphosphonate according to the minimum standards of care. Although if you're with a clinic that's pushing that envelope, perhaps you are on a bisphosphonate. But if you're not on steroids and you're ambulatory and you've never had a fracture, then the indication for that is less clear. But I would be following the bone density very closely. And overall, we have a very low threshold for protecting the bones and starting treatment. And the reason for that is this: we know that the steroids help muscles. We know that they're helpful to the cardio and respiratory function. And we want patients to be able to stay on steroids for as long as they choose and not have the benefits of steroids outweighed by the osteoporosis. So we protect the osteoporosis early, we prevent against it, so that the muscle outcome is that much more favorable.
I would add on to Dr. Ward's in talking about the adult patients with Duchenne, that it gets a little trickier. There are other drugs that are FDA approved in adults that we haven't studied thoroughly in children. Dr. Marion Runner had published a paper about using teriparatide, which is a PTH like drug, which is an anabolic agent, meaning it's supposed to stimulate bone to be made, whereas zoledronic acid is an anti-resorptive and stops you from breaking down bone. And in her study, they'd all been treated with high doses of these bisphosphonates and then switched over to the teriparatide. And it didn't increase it as much as you expect to see it, as you see in other populations, like in your postmenopausal osteoporosis, you sort of your grandmas who are shrinking. But they didn't see a decline in bone density either. There's some questions on if there would be better response if you were bisphosphonate naive, because in the postmenopausal osteoporosis, you do see a better anabolic response. So if you have made it to 18, because one person said that they did without being treated with zoledronic acid and your bones are fused, it's a conversation to talk about. It's not the standard of care. It would still be a very experimental drug to try, but it's different agents that are out there and other options to consider.
This next question, maybe Dr. Ward or Dr. Merchant can answer. What options are there to check for bone health for boys who have had a spinal fusion or contractures and it's difficult for them to lay for a DEXA scan?
Yeah, that's really tricky. So if you just have contractures, in terms of the DEXA, you can do lateral distal femur DEXA, and that's when the individual is placed on their side with a little foam block in between the knees. And that's a very comfortable position. And you can do the DEXA at the lateral distal femur, so just above the knee from the side. And there are normative data for that as well, at least for hologic machines. So that's one option. If you have contractures and you're trying to just do the spine x-ray, the knee contractures, spine DEXA rather, the knee contractures won't get in the way of that. So you should be able, if you have knee contractures, to do the spine DEXA. And then if you've had surgical intervention, then it is more difficult to see what's going on in the spine. So you lose the spine imaging. Now in Ottawa, we have a special machine called PQCT, which allows us to look at the bone density and the shape of the bone and the muscle mass at the leg, the tibia. Now that's not widely available, I must say. You can also do by DEXA the forearm and get a BMD from the forearm. So in cases where you have spine hardware, you can look at the forearm by DEXA and the tibia by PQCT if the latter is available to you.
That's awesome. I didn't realize you could do the forearm.
I mean, also add on to the DEXA, like there is somebody asked about corrected versus uncorrected Z-score. And so we do have some normative data, and based on the height of the child, we will do like corrected Z-scores, but we also have to take into account puberty that I will look at and see where they are in puberty. But a lot of it is also comparing the DEXA for the same patient, like for the same person. We kind of want to follow the trend and see how they're doing is really important. And also using the same machine or like the same does help too, because the data can vary a little bit.
Okay, so and my next question is probably for Dr. Ward, but everyone can respond. I think there's still some confusion, and actually we received this question a lot. We've talked a lot about DEXA scans, but when do you use a DEXA versus a lateral spine x-ray, and when would one be appropriate? You just talked a little bit about that, but could you give maybe like a general guideline?
Yeah, so the most important test is the spine imaging. And I say spine imaging instead of x-ray because some sites use the DEXA to look at the bones, those little ice cubes. So that's why I use that language. The reason the spine imaging is so very important is that if there is a vertebral compression fracture, which isn't like a long bone fracturing, it's a squishing kind of fracture, that is an automatic reason to be on bone protection therapy. So knowing whether there's those fractures or not is absolutely critical to the care pathway. So that is number one. If you don't have a DEXA machine, I can take care of you. I really don't need my spine imaging. So I try to emphasize that the DEXA is not as important to us clinically as you all think. The reason that it always seems to figure so prominently in discussions is because 30 years ago, when we started to think about children's bones and adults' bones in the chronic illness setting, the DEXA machines were all just coming to the fore, and institutions were purchasing them, and people were getting that set up, and there was a lot of excitement around them. It took us a long time to sort of figure out, hey, wait a minute, the most important thing is still fractures. Let's figure out really how to carefully evaluate fractures and then relate those to BMD to better understand how we should be using our BMDs in the clinic. So the field has shifted now to the importance of knowing whether you've got those asymptomatic vertebral fractures, definite indication for treatment, non-vertebral fractures, definite indication for treatment. The bone density guides us if it's going down in knowing if we need to do our imaging more often than every 1 to 2 years. And then when we start testosterone or we start bisphosphonate therapy, we want to see that BMD go up. Sorry about that. So that's my narrative about imaging and bone density. Bone density is part of the puzzle, gives us information, but certainly the imaging is that much more important.
And you mentioned that sometimes those compression fractures can be asymptomatic. Can you talk a little bit about when? I think people don't recognize that. They think if they don't have back pain that maybe they're not having those contractures, and how often that happens.
Yeah, I'm so glad you raised this point. This is one of the things we've learned in the last 10 years that was really a game changer in the way that we think about bone health monitoring in Duchenne, but other conditions as well, like cerebral palsy and leukemia. So these fractures, even when they're moderate and severe, can be asymptomatic, that is, without any back pain at all. And yet they're a definite sign that the bones have lost their strength. So why are they asymptomatic? It's because when the bones in the back, which are normally square, start to compress, they do so, what we say, insidiously. They do so very slowly, unless you've had a fall, but they just sort of collapse a little bit over time. And at first, we can't even see it on X-ray, actually. And this slow collapse comes without pain because it's so slow, so gradual. Now, if somebody has a fall, I often hear that somebody may have had a fall and then they had back pain, and then you do an X-ray and you see the collapse. Probably the collapse was already starting, and then the fall just made it that much more obvious. And that's why we recommend imaging the spine around the time of diagnosis, no later than steroid initiation, so that the clinicians, when they repeat it 1 to 2 years later, ideally 1 year later, and 1 year after that, they can compare to the first one to see if there's those very early signs of the spine starting to collapse, even if there's no back pain.
Anything else to add to what anyone sees in clinic?
I think that's really helpful. This next question, Dr. Merchant, maybe you could speak to the effects of a stander. Does that affect bone health, and should patients be using that a standing frame?
So I think that when they're not, so if you're non-ambulatory with the standards, my concern is so we do know that weight bearing helps for bone density, but I also think there's a fall risk, and Leanne might have more of a, like from whether or not to use the standard to stand, because I think they also is contractors, and so it becomes a little bit difficult on what's the best thing. And I think it's individual patient by patient based.
Yeah, that's a really great question. We get this question in individuals with cerebral palsy as well. So here's the thing. What drives bone strength in terms of muscle is the muscle contraction. Okay, when you're in a standing frame, you are contracting a little bit in order to maintain your positioning, but you're not contracting as much as you are if you're walking or jumping or running. So the benefits to a standing frame are modest compared to obviously the benefits of just being ambulatory. So I agree with Nadia. It's one of those things where I don't prescribe a standing frame automatically to my patients, because I think the benefit is not really necessarily there to truly justify it as a standard prescription. And as Nadia said, you have to be so careful about falls when you have contractures with their knees or ankles or hips, more difficult to stand. And so I think this is something that, if you can do it and you can do it safely, I don't see any problem with that. There may be some minimal, modest benefit, but if it's not something you can weave into your life, I don't think that you're losing out in any clinically important way.
Thank you. That's really helpful. Sort of following up on that, I think we can all agree that prevention is the best approach when it comes to fractures. Can you guys share your best tips for things that maybe families don't think about, as far as staying safe in the home and out of the home and at school, and what you like to recommend just to prevent falls and fractures?
So one, I'm going to say, when we're talking about weight, I'm also going to say vitamin D and calcium. It's really important for prevention from the beginning that children have a good calcium diet. So foods that are good, enriched in calcium. So milk, cheese, yogurt. I mean, that could be almond milk, but other forms of high calcium foods, and making sure we have a good vitamin D is also really important, because you need that calcium to build bone. So that's kind of a good prevention, but all throughout. And then if you're on steroids, you may need vitamin D supplementation, because you need a little bit more vitamin D if you're on steroids. So that's my one tidbit. Let's go. We can go around the room, to the.
I agree.
Go ahead, Janet.
I agree with Nadia and the calcium and vitamin D. I'm a little cautious with calcium D because I've had a lot of kidney stones in our patient population. And so making sure when you're monitoring the calcium intake to also be following urinary calcium and knowing that you can't use the urine calcium to creatinine ratio in this patient population, that you have to standardize it some other way because the creatinine is so low because of the muscular dystrophy. And then the other point that I emphasize a lot is just safety and transfers. If you can fit a Hoyer lift into the household, and if you can't, working and trying to get the house as ADA compliant as possible for safety and transfers. Part of the issues with weight is I know a lot of parents are the transfer, particularly in the beginning, and keeping the weight at a level that can keep the parents' backs healthy as well is a big issue.
I agree. And I would just add to that, I live in Canada and we're considered a Nordic country, and we forget that. We just get so used to the snow and the ice. But, I've seen caregivers slip on the ice with a boy with Duchenne in their arms, and then we have two injured individuals. So I recommend in icy places that the caregivers have those yak tracks that they put on the bottom of their winter boots, or the ambulatory boy, and those really, I wear those in the winter. They really grip the ice. So just as Dr. Crane is saying, so important to think about safety. You can fall out of your wheelchair if you're not strapped in. You can fall out of your wheelchair if you're doing fancy spinning things that I know sometimes are fun to do, but certainly we've seen some significant wheelchair injuries, and we certainly want the boys to move around and do what they need to do as part of their lives and their social engagements, but having some sense of, if I do fall, I'm going to be at increased risk of some setbacks. That's sort of part of the narrative, I think, and I just really agree with Dr. Crane and Dr. Merchant otherwise.
Thank you. And one question, so we have both families and clinicians watching today, and we talked about this a little bit before, but do you guys have any advice for families or providers who are unable to get that the IM Solu-Cortef approved by insurance as part of the steroid stress dose from the PJ protocol? Dr. Merchant?
Yes. So one, I always want my families to have a letter that has adrenal insufficiency. So that way it's easy for if it's something emergency does happen. Now the Solu-Cortef sadly is really hard to get approved, even for my patients that do not have Duchenne muscular dystrophy, but have that need for other reasons. So we have to write letters and do prior auths and appeal sometimes. It's a little bit of work, but we have letters that we will write with the insurance to say why we want it covered. But I really do think it's important that we do have it available, because if a child fractures, but the EMS does not carry Solu-Cortef often, so the child can get it while on the way to the ER if they're not able to take to anything by mouth. And so it's really important that we do have Solu-Cortef, the injection steroid. And I know it's a little bit of work, but that's just, we're used to doing prior auths for other things in Duchenne muscular dystrophy, and so this is another one. It may not be everywhere, but this is definitely in the US that I know we have a challenge. I don't know about Canada.
No, I don't have that challenge, fortunately.
Thank you. That's really helpful. And then one last question, as we look at the different types of steroids, there is vamorolone, which could be potentially approved in the US later this year. Dr. Ward, could you speak to vamorolone's effect on bone health, how it compares to prednisone or Emflaza? Have there been studies looking at that?
Yeah, so vamorolone, when I think about vamorolone, this novel dissociative steroid, I think about the effect on growth, what we understand about that through studies, and the effect on bone strength and bone metabolism. So just as Dr. Merchant said in her portion of the talk, vamorolone appears to be bone preserving in terms of growth. So the children seem to be growing really very normally on vamorolone. And I know for many that short stature that comes with classic steroids can be quite concerning. So it results in improved growth from what we can see. The other aspects that I mentioned in terms of bone strength, what we know is that when we looked at vamorolone compared to daily prednisone and daily deflazacort, after about 3 years of all 3 agents, that vamorolone appeared to be associated with fewer vertebral fractures. So it appears, based on the data that we have so far, to be relatively bone sparing in terms of bone strength. Now, that doesn't mean that a child on vamorolone should not have bone monitoring. We know we need to continue with bone health monitoring until we understand the effect of this agent on bone in more detail, but so far it's looking favorable in terms of vertebral fractures. And then we also looked at bone metabolism, blood work that teaches us about how active the bone is, and the bone activity. The bones are not sleepy like they are on classic steroids. Their level of activity is essentially normal from what we can see. So that's another way in which vamorolone seems to be different from classic steroids. So thank you for that question. We still have things to learn. I was just going to say, we still have things to learn about long bone fracture rates on vamorolone, for example. And so this is ongoing studies being carried out. Thank you.
Great. Thank you so much. It looks like we are at about time. So I just want to thank our panelists. I know I learned a lot. This was a great conversation, and we'll definitely have you back again anytime you want. So with that, I'm going to conclude today's webinar. I'm going to throw up a quick slide just sharing PPMD's care team email. So if anyone has any questions from this webinar or things that they would like to follow up on, please email us and we will get back to you. So with that, thank you everyone. Thanks for spending the last hour with us. And we will see you soon. Thanks.